Uh, Hello! Good evening, everybody. And wait, where's chat? Chat is not seen on the chart. Oh, there we go. There we go. Hello, everybody. Good evening. Hello, Pokari. Hello, Abdul. Hello, sino to? Archetype. Hello. Denison Pons. Hello. SwitchCon. Hello. Welcome to the stream. Hello, how are you guys? How you guys doing this weekend? Good morning. Oh, it's morning over there. It is evening, 9 p.m. over here. Hope you guys are doing okay so far for this weekend. Yeah. Good, played League all afternoon. Oh my god. What kind of life? O kari wala kang buhay. Ang buhay. Anyway, so it's been a while. Has it? Wait. Yeah, I think it's been a while since I had my last formal medical education stream, I think. When was the last time? The last topic I had of a formal medical education stream was appendix, yeah? I think, kailan ba yun? When did I don't even remember when my last medical education stream was. Was it November? Or was it last month? I don't know. Just subscribe lately, but I've been following you on FB Duck. Just keeps forgetting to subscribe here. That's okay. I understand that. That happens to me also with like other streamers or VTubers. Like, oh, I'm following them and I forget to like follow them on their other on their platforms. Hi Birion, good evening Shiori Sensei. Viora introduced you at her stream kanina. Oh, hell heck, okay. Welcome. Yeah. For those who are new here, yeah, I am more active on Twitch, but I'm starting to do more frequent streams here on YouTube, trying to. So I'm gonna try doing at least one stream on YouTube a week, at least. We'll see if I can do two. We'll see if I can stuff in like two streams. But I'm gonna try being alternating between Twitch and YouTube. I'm gonna try that. So, but so far I am most active on Twitch. So if you wanna catch me gaming and all that, and being gremlin, it's on Twitch. But if you're not a Twitch person, like I know some people don't like sometimes they don't have Twitch, they don't like Twitch. I don't know, by preference. I do upload VODs on a separate channel, the ShioriPon VODs channel, so you can just watch my gaming streams there. I usually upload them as premiere, so when they just like go live, but it's not really live, it's just premieres. So it looks like a live stream, but it's not. But yeah. Okay. So, tonight, we're gonna talk about hernias, okay? I know I talked about hernias before on, I think it was 2 years ago. Let me open up my YouTube channel. I think, was it 2 years ago or 3 years ago? I talked about, I did hernia before, using my old model. Saan ba yun? Let's look all the way back. Wait. Ito. Ay, hindi. It's a video. I think ito. Okay. It was a video. I'm gonna scroll all the way back. Operation Tuli. Was this? Did I have that one first or the hernia first? Oh, I had a lot of medical education streams already. I think it was 2 years ago. my last med-ed stream where I talked about, my hernia medical education stream. That education stream was it was very short, or it wasn't as in depth as what I'm gonna do now. I think the last time I did that, when I did hernia medical education stream, it was only about inguinal hernia. It was only about inguinal hernia. And I did not discuss like the other types of hernia. As far as I know, I looked at my old PowerPoint also, and it was just inguinal hernia. So I'm gonna talk about the other types of hernia. We're gonna go a little more in depth. Here we go. I found it. It's 3 years ago. Medical education stream hernia. It was 3 years ago, yo. My hernia stream. That was a long time ago. So yeah. Okay. Yeah, it was that long. Anyway, let's bring it up. Okay. Hey, what the hell? Bakit? Why is it not? Oh. Why is it only capture? Wait, it's not capturing the PowerPoint. What? What? Oh, okay. I see why. There we go. That was just a tip. Yeah. If you mean tip of the iceberg, yeah. There's a lot. Oops. There's a. There we go. Let's change that. Let's use this BGM. Let's use this BGM. Doc, may quiz po ba mamaya? Syempre, may quiz yun. There's always a quiz. Alright. I got my tablet ready so I can use my, my pen. Yeah, my pen. No, well, you reminded me. May teacher's pet dito. Ni-remind ako. So, wala. Sorry na lang kayo. 1/4. Mamaya na kayo mag-ano. You can worry about that later. Let's use a laser pointer. Laser pointer. Yay, my quiz. Alright, so we're gonna talk about hernias, okay? Do you guys know what a hernia is? What is hernia? Okay, chat. Okay, chat, we gotta make this interactive. What is hernia? What do you guys know about hernia? Sacrifice natin. Ito, what do you guys know about hernia? I wanna know what the chat says. Lus. Okay, so, chat says... Lus. What else do you say? May lumulusot sa di dapat lusutan. Okay, lumulusot. Lusot. Okay. Holes in the body. God, holes in the body. Bro, that is so... Holes. Okay, what else? Kung merong hernia, meron din bang Do I have a mod? May mod ba ako dyan? Pwede pa, pa-time out nga si... Pa-time out si Recycled Cabbage. Pwede pa-time out si Recycled Cabbage. Buisit talaga. Nakakainis. Wala yata ang mod. Wala si Wendell dito. Wala si Wendell tsaka si Cyrus. Hindi akin so hernia. Diyos ko naman, ang kokorni nyo! Ang kokorni nyo. Okay. Baka meron din Dania. Wala yung mga mod ko. Mga absent, mga late yung mga mod ko. Yung mga mods ko, mamaya sa quiz, mods. Mods equals minus 50 points sa quiz. Kasi late! Because late. Okay? Anyway, okay. So, for those who answered luslos, yeah, luslos is technically Tagalog. It's just that for those who are not Filipino, luslos is the Tagalog word of hernia. It's the Tagalog or the Filipino word of hernia. And when they say lumulusot, it means how do you say? Passing through? I don't know if that's right. Was this lumulusot sa dapat di lusutan? Basically, something passing through or going inside, passing through where it's not supposed to. Something like that. Chronicles of Hernia, the one with the lion. Isa pa to! Isa pa tong si Rain. Wala, wala kasi ang mod. Dapat tina-time out kayo. Okay, and then someone said holes. Technically, it is kind of like holes. Not really, but it is. Lagay si listahan sa blackboard. Okay, so a hernia here. Okay, next. Sorry, let's go to the next slide. Okay, a hernia is when an internal organ protrudes through a weakness in the wall of muscle or fascia. So there's a weakness in an area of your body, and an organ passes through when it's not supposed to. Okay, so there are many types of hernia. You can have a hernia. The most common one is inguinal hernia. Okay, but there's a lot of types. I'm only gonna cover the more common ones because there's a lot. Okay, there's inguinal hernias, umbilical hernias, incisional hernias, ventral hernias, which is where umbilical hernias is under ventral hernia. There's also femoral hernias, which I have not seen actually. There are also stuff like internal hernias, like diaphragmatic hernias, and there's even like spigelian hernias. There's many kinds. Okay, there's a lot of hernias. I thought lus is only in the... Oh, no, it's not. It is not. It's not. That's an inguinal hernia. Okay. So, a hernia is what is this, okay? So, it doesn't only... When you say hernia, it doesn't only mean inguinal hernia. But it's an umbrella term for every part of every area of the body where there's a weakness and an internal organ or something passes through when it's not supposed to. So it can be in the inguinal region, going to the scrotum. It can be in the abdomen. It can also be in the spine, a spine. It can be in the diaphragm. Like, if, for example, an example of diaphragmatic hernia would be when you have a hole, a congenital defect in your diaphragm, which is the muscle that separates the chest from the abdomen. It's a breathing muscle. And what happens is your stomach or your intestines pass through your diaphragm and into your chest. That's a diaphragmatic hernia. And that's not supposed to happen. Okay? Parang titi. Ano parang titi? Okay. Oh, here we go. Types of hernias. Okay. So here we go. We got a representative image showing some, if not all, of the types of hernias. We got the So if the hernia is like in the middle of the abdomen, it's under the term ventral hernia. So we have epigastric hernia, which is a hernia in the upper abdomen. We have umbilical hernia, which is at your belly button. We have incisional hernias. Usually they're in the abdomen too, because incisional hernias are hernias that happen at the site of a previous incision. Like, say you got surgery before and then you get bulging from that area after a while. That's a hernia. There's inguinal hernias, and there we go. There's direct and indirect inguinal hernias, and then there's the femoral hernias. Okay, there's a lot. There's way more than this, but these are the most the basic ones. Last time I only talked about inguinal hernias. So let's talk about inguinal hernias first, because these are the most common ones that we see. Okay. So as a surgeon, and as I'm do we have any medical students here or anyone in the medical field right now in chat? Because if you are me, oh, okay, nice. Wait, are you guys med students or what? What are you guys? Interns, med students, residents? You're gonna have to know this. Was studying hernias the other day. There we go. We got some. Nice. Okay. Oh, well, actually, as a med student, I don't know if you have to memorize all of this. It's more of surgery. But, you see this? This is the anatomy of the inguinal area. And, to be honest, I'm gonna be very honest with you guys. Even I have problems with this, okay? Even I have a hard time with this. It looks so good on paper. It looks so good illustrated, but when you start doing surgeries, you don't understand what the hell you're looking at. Cause every patient is different. Their inguinal area looks different each time. So like, you can master this image, but then when you start doing the surgery, you don't know what the hell you're looking at when you open up the patient. It's like, there are some patients that have the perfect anatomy. Like, you would see all this shit, but then there's other patients that, alam mo yung sobrang gulo na itsura. It looks bad. It doesn't look how it as illustrated. But then may cheat sheet kayo during surgery niyan. No. Because the thing is, the more you operate on hernias, the more you get the basics down. Like, you start being familiar with it. It's just something like when you're in your first year residency and then or your second year residency and then you start doing hernias, you don't know what the hell you're looking at. Yeah. Aha, there's Wendell. Late. Wendell, late ka. Mga mods, late. Minus 50 kayo sa quiz mamaya. Minus 50 points. Late. Okay, anyway, but to be honest, this thing, it's, I have not really mastered it. Okay. I was here, di lang nag-chat cause I'm shit. Leche. Too much information, man. Halang ya ka, Wendell. Si Wendell nanonood ng stream ko habang tumatae. Ganun ba? My God. My stream is so chill that you can watch me while you're taking a shit in your bathroom. As a surgeon, kailangan ba na-memorize lahat? Oh yes! As a surgeon, you need to know your anatomy. You really need to know your anatomy. You really need to know your anatomy. You can't be a surgeon and not know your anatomy. It's your bread and butter. It's the bread and butter. You have to know the anatomy. Because if you don't know your anatomy, you don't know what you're doing. You don't know what's what and you don't know where's where. You know? It's just that hernias, inguinal hernias are very complicated because there's a lot of layers and a lot of structures there. So for example, I don't even know where to start here. Okay, this one, see, there are many layers when in the inguinal area. So you have to know all these. Like, see, once you open up the skin, pass through the campers and scarpus fascia, or the fat, the next thing you're gonna see after going through all the fat is the external oblique aponeurosis, or the fascia of the external oblique, which is connected to the external oblique muscle. So you're gonna open that. And then once you open that, you're going to see You're going to see over here pala. You're going to see this. This is the superficial inguinal ring. So it encases the contents of the inguinal area. For males, for men, this thing you see here is the spermatic cord. You boys have this. Us women don't have this. Okay, that's why when we do a hernia on men, it's kind of easy to identify the spermatic cord. It's just this tubular thing that passes through. It's a tubular structure that has multiple things in it. It has like blood vessels, nerves, and your vas deferens. Okay. Yeah. So once you open this, you'll see the cord and the hernia, right? Sometimes there's another ring here. So if this is the superficial ring, there's the internal ring. This one goes into the abdomen. Here we go. Deep inguinal ring or the internal ring. When you pass through that, it's the abdomen. This one goes to the scrotum or the balls. So, when you have you just have to be careful when you're cutting. You shouldn't cut too deep, especially here on the side, because see this? There are big ass vessels right here. The femoral vessels. Okay? You do not want to pierce these vessels because that is very bad. That is very bad. You don't want to touch these. You don't want to cut too deep. Okay? You just gotta cut here. Just this. You just open this thing and you don't go any deeper. Okay? How do you cut it open? With a knife or with an electrocautery? Are those layers easily distinguishable? They should be. Especially the external oblique. You should be able to identify it. It depends on how bad the hernia is. There's some hernias that are really bulging. Like bulging out so much. I will show you photos later. Since we're on YouTube, I can show photos uncensored. We'll go Google some photos. Anyway, so when you cut this open, you're supposed to see this kinda. This is the inguinal canal, and this is where the spermatic cord passes through. Okay. And then for those med students there, you gotta memorize this. Hasselbalch's triangle. You know what's funny about this? As med students, you gotta know this, but when you're a surgeon, you barely really use this. You barely talk about the Hasselbalch's triangle, okay? But if you're a med student, you gotta know this. But if you're a surgeon, you don't really care. They don't pay much attention to this anymore. Because you know why? Because the reason why we don't pay too much attention to this anymore is because majority of inguinal hernias are indirect. So you just know that the hernia is just gonna pass through the canal. Because you know how for the med students out there, the importance of this Hasselbalch's triangle is to distinguish direct and indirect hernia, okay? So remember this for your exams, okay? If the hernia passes through the Hasselbalch's triangle, it's a direct hernia. But if it's here, it's an indirect hernia, okay? And you also have to know the borders of the triangle. So you have to know that the upper or the medial border of the triangle is the rectus abdominis muscle. See? Lining it, it's the muscle, the rectus abdominis. And then superior boundary, the upper boundary is the inferior epigastric vessels. Okay? And then your lower boundary is basically the inguinal ligament. Alright? This is your cheat sheet. Guys. My yeah, the importance of the Hasselbalch's triangle is just this is one of the weakest points in the body. That's why if you have a hernia that passes through here, this is the weakest spot. Okay? It's the weakest area. One of the weakest area in this part of the body. Alright? Okay. Alright. Ang hernia badok may similar sa ba sa lipoma? No, lipoma is totally different. Lipoma is a tumor. Oh. And then below the inguinal canal, below the inguinal ligament is the femoral ring. So, femoral hernias go through here, but I have not seen a femoral hernia yet. To be honest, I have not seen. Majority of hernias are common hernias are the indirect inguinal hernias. Okay. So take a note. All right, inguinal hernia. There we go. So this is a male. This is in a male body. Okay. A normal inguinal area should look like this. There's a wall separating it. There's a wall separating, or at least there is no space open and accessing your balls, okay? Your scrotum. The only one that's supposed to have access is your spermatic cord. Okay? Now, you can have a hernia. You can have a hernia that goes all the way to your balls, okay? You can have a hernia that goes all the way to your balls. That means your intestines are fat inside the body. The omentum just passes through and goes here. This is what causes your balls to get big and swell up, okay? Sometimes there are hernias that only go halfway, like this. Okay? Just seeing these diagrams make me wince. May dumadaan na food sa itlog. Oh, isaw na pumupunta sa itlog niyo, di ba? Okay. So yeah, that's how a hernia. That's what happens when you have a hernia, an inguinal hernia. Okay, whatever is inside your abdomen passes through, and then it can reach your scrotum. Sometimes it doesn't. Sometimes just gets stuck here, but doesn't reach the scrotum. But in some cases, it goes to the scrotum. Okay, and this is supposed to be the normal. Isa what quick combo. Okay, here we go. Direct inguinal hernia. Okay, direct inguinal hernia. So like I said, where your Hasselbalch triangle is here. See this? There's a little supporter that's trying to go through the hernia. See the triangle? On the medial side is the muscle, the rectus abdominis muscle, and then you have the inferior epigastric vessels on top. And then the inguinal canal right here, or the inguinal canal, or the inguinal ligament over here. Okay? And then if you have a hernia going through there, you have a little supporter that's trying to squeeze itself through here. That is a direct inguinal hernia. Okay? Now, if we're gonna talk about indirect inguinal hernia, there we go. See? It's outside the Hasselbalch triangle, and they pass through the inguinal ring into the inguinal canal. So see this supporter, it's going through here. Okay. Now the femoral hernia is below the inguinal ligament over here. Okay, so this is little supporter that's trying to pass through. That's a femoral hernia, which I have not really seen and operated on yet. Because most of the hernias I've operated on the inguinal, in this region are the inguinal hernias. Okay? Alright, next. I hope you guys understand so far. You guys understand? You guys get it so far? I think... Oh, here! We got some, a table here. So, indirect inguinal hernia. So, look. See, it is the most common on all ages. Both sexes. Usually in children, okay? Indirect inguinal hernia is usually in children, but sometimes adults have it. So, it usually goes into the scrotum because it passes through the canal into the scrotum. Okay? Now, if you have a direct inguinal hernia, usually these are adults. Rarely children, okay? Rarely in children, rarely in women. And it passes through like more medially in the middle than in the canal, like I said. And these hernias don't really go to the scrotum. Rarely go to the scrotum. Okay. Femoral hernias are more common in women than in men. So it's below the inguinal ligament. Okay. And of course, since it's below in the femoral area, it does not go into the scrotum. Okay. So that is the difference between these three. Okay, there is a way to do a physical examination to determine if it's indirect or direct, but like this, you have to touch what we do is we put our finger through here and then we feel this area. So if you've ever had a physical examination where they feel through your scrotum and feel this part, and then they'll tell you to like bear down or cough, they want to feel if the hernia is if the contents of your hernia is gonna touch the fingertip or if it's on the side of the finger, and they'll know if it's indirect or direct. But to be honest, I don't usually do this anymore because most of the hernia patients I've seen already have like an ultrasound done. And either way, whether direct or indirect, you're gonna do surgery anyway. So yeah. Free ball squish. You don't squish the balls. You don't squish the balls, okay? Alright, so after inguinal hernias, let's talk about ventral hernias, okay? When we say ventral hernias, these are more in the abdomen, in the middle of the abdomen, okay? So there are different types of ventral hernias, but I'll talk about the most common ones that I've seen. So what is the umbilical hernia? Which is basically a hernia in the belly button or the umbilicus here. So these are mostly seen in children as well, like newborn babies. Okay, over here. Excuse me. Okay. Wait, I'm gonna take a drink. Okay, so umbilical hernias are usually in babies, like newborn babies, but they can also happen in adults. Okay, so these are the ones that have, if you have a funky looking belly button, like a big belly button with a bulge, then you most likely have an umbilical hernia. So go check your belly buttons right now. Check your belly buttons right now. If you have something bulging there or it looks weird, like it looks like how do I draw? Usually it looks like when I draw it, oops, drawing natin. Like it looks like a little, there's like a bulging circle like this. It's like a bulge right here. That bulge. Yeah, there's like a bulge in your belly button. That's you most like, if you have that, yeah, it's most likely have like a umbilical hernia. Just bulge. There's like a little bulge. And then if you press on it, like say you have that. If you press on it, you'll feel a defect, like a little hole. Like a weakness. Okay, that means you have umbilical hernia. And if you have that, you gotta you can opt for surgery. If it doesn't bother you, then sure, you can just have it electively. It's not an emergency if it doesn't bother you. But if it bothers you, go get surgery. Alright. Is this different from innies and outies? What do you mean by innies and outies? What do you mean? Matitigas bang hernia, doc? That depends. That depends. We'll get to that. Okay, we'll get to that. Most umbilical hernias are on children, like babies. So like when a baby's born and they have a bulging belly button, it means they have an umbilical hernia, but we don't do surgery on those. Because eventually that hernia will close. Because you know how newborn babies are born with their umbilical cords attached, right? They still have their umbilical cords attached, so that's why there's a hernia. It will eventually close up. So that's why when babies have when a baby is referred to surgery for umbilical hernia, we tell them just wait it out. Wait for them to reach like 5 years old. If that umbilical hernia is still there, then we can repair it. Okay, but if it usually it closes by then. All right. But if you're an adult, then you gotta have surgery for it. All right. It's a bit weird that whenever I touch my belly button, I feel something at the tip of... Oh, that's because you have, there is a connection between that and the urethra. There is a, what do you call that? There's a congenital... No, it's not congenital. An anatomic connection that, connects the umbilicus or the belly button to the urethra. What is it called again? Shoot, I forgot what it's called. But that's the reason. But it's the reason why when you play around with your belly button, you feel like peeing, something like that. Yeah, like if you play around with your belly button, you feel like peeing. What was it called again? Urachus. It's it's the urachus. It's like a cord connecting the belly button to your bladder. It's something to do with embryology. You're born with it. As a baby, you have that, and then what happens is it just gets smaller and smaller as you get older, or when you're born. It's supposed to like fibrose or get smaller or atrophy. Spelling? Okay, spelling. Wait lang. Urachus. That's why when you clean your... Yeah, that's why. It's, you know how when you're a fetus, when a baby is a fetus, and they're inside the mother's womb, you know, everything, all the nutrition and all the waste of the fetus is through the umbilical cord, right? It's through the umbilical cord. So that means, was this the bladder, urine? Your urine as a baby passes through your umbilical cord. Because what happens is it's the mother's body that helps that, you know, takes care of that. So when you are born, or when you are a baby already and not a fetus, the urachus, or the connection between that, the belly button, the umbilical cord to the bladder, is supposed to like get smaller or fibrose. Okay, so that's why. It's an embryology thing. All right. Belly and pee-pee are the same. No. Anyway, okay, next. Okay, next ventral hernia is the incisional hernia. So just by the name itself, it's from a previous incision or a previous surgery. Okay, so here we go. We have an example here. Let's say this patient had surgery in the abdomen. He had surgery in the abdomen and I can't. Oh god, I can't do that. Oh, there we go. He had surgery in the abdomen before, let's say an exploratory laparotomy. They closed it, and then few months or a year and a few years later, there's a bulge. He starts noticing a bulge, just like this. That is an incisional hernia. So if you have a bulge near a scar, most likely it's an incisional hernia. It means the sutures or the scar inside when they close your abdomen either opened up or didn't hold on. It wasn't able to hold out, and yeah. What's the difference between incisional? Excision is when you take out something. Incision is when you cut. So incision, when you cut. Excision is when you remove. So, yeah. That's why, you know, incisional hernias can happen in any abdominal surgery. So if you had an appendectomy, for example, you had an appendectomy. An open appendectomy. If you had an open appendectomy, usually the incision for an appendectomy is, let's see, this is, usually it's here. Usually the appendectomy incision is here, right? So, let's say, bumigay yung sutures, or, after a while, you know, the fascia weakened and then you start having a bulge. If you have a bulge near this area, that would be an incisional hernia because of your appendectomy. Also in laparoscopic surgery, let's say you had your gallbladder removed. In a gallbladder surgery, your incisions would be here. You would have one here, and then you would have one here, small ones, and then so here. And then sometimes you'd have one right here. Like, sometimes it's lined like this, or sometimes it's a smiley. No. Usually, if there's an incisional hernia here, like, they would have a hernia in the umbilicus, like an umbilical hernia, but then they'll say, oh, I had surgery for gallstones before, laparoscopic cholecystectomy. It becomes an incisional hernia. I saw those kinds of bulges in some C-section ladies. Yeah, there. They also have. So the reason why you would have a hernia in the incisional sites is because, you know, we call it like your abdomen is not a virgin anymore. Any incision made in that area, that means it's like a violation of the tissue, right? A violation especially of the fascia. So what happens is it's weakened. It's not as strong as it used to be. Like, if your fascia holds up 100%, and then you had a surgery done, you close it, then your fascia is like it's not 100% anymore. Probably like 90 or 80, something like that. Gets thinner. Yeah, because it's a fibrosis, because of scarring, fibrosis, and all that. That's accurate, but I have 2 lesser incisions from me missing a gallbladder. What do you mean by 2 lesser incisions? You had only 2 incisions? Is that what you're saying? What do you mean by 2 lesser incisions? You only had 3, or you only had 2 incisions, or 3? Is that common to occur? Not as common. It depends also on the lifestyle of the patient. It depends on the lifestyle of the patient, because 3 incisions. Yeah, there are some surgeons that do 3 incision laparoscopic cholecystectomy. Like, they would have one here, and then one on the side. Majority of surgeons who do this, they have 4. There are some that do 3. I've seen that. And there are some that have like only 1. I have seen a laparoscopic appendectomy done with 1 incision. It was just here. It was cool. It was pretty cool. Okay. Yeah, 1 incision. It's pretty cool. Alright, next. I think, yeah, that's all. Parastomal hernias. Okay, when you say parastomal, you know those patients that have colostomies? That's what that area where the colostomy is called a stoma. Okay? So here's an example. This is per patient with a colostomy or an ileostomy. You know, a colostomy or an ileostomy is when you bring out the bowel. Let's say they had a surgery for obstruction or cancer surgery, and they weren't able to put the bowel back or reconnect the bowel. So what they do is they put a colostomy, right? So what happens is you have a new butt in your abdomen. This is your new butt. Your new butt. This is where you poop instead of in your anus. So you can have a hernia in that area too, because it's still an incision. It's a violation of tissues. So this is what happens, see? you get bulging in the area of the stoma. We call this the stoma, where the bowel is. We call it the stoma, and then there's a weakness in that area. There's a weakness here, so what happens is the bowel just passes through. Or the large intestine or even the small intestines pass through. Yeah. So you gotta repair that. Okay. So that's I have seen parastomal hernias, but then they weren't that worried. They weren't that like I know I had a patient like that. He was supposed to have surgery done, but he didn't follow up. He was lost to follow up. I guess he didn't want the surgery done. I've seen a lot of that in Bantay Bata ads in 90s and 2000s. Usually tinatakpan lang na sila. Oh my gosh, I know some patients who don't buy colostomy bags. They cover it with like gauze. And like, how the hell do you do that? You just cover it up with gauze? Imagine if they poop, it's gonna smell, and then they just change the gauze each time. Like, that's so tedious. Like, you can have a bag. You just put a bag on it, and then you just drain the bag. But yeah, there's some who do that. They cover it with plastic. Some cover it with cellophane or random plastic. Yung plastic na ginagamit pang soft drinks. Yan. I've seen. Okay, so, next. Oh, risk factors for hernia. Okay, here we go. So what, risk factors for hernia? So one is, obesity or being overweight. Mostly obesity, okay? This is me pooping so much. Sitting on the toilet for prolonged hours or exerting effort on your abdomen. Like, let's say you need to poop. And you have the hardest shit ever. And what you're doing is you're trying to force it down. Like, I need to poop. You start forcing it down. That's putting pressure in your abdomen. Also when you pee, let's say you have a hard time peeing and you start putting pressure, like you start forcing it. That's one. Basically, anything that applies pressure into the abdomen, increased pressure will increase your chances of getting a hernia. Especially if you do it for a long time. Like you've been doing it for years every day. Then yeah, you're gonna have a hernia. Oh, here, enlarged prostates. So as most people who have, most men who have a large prostate, they have a hard time peeing, so they have the tendency to like force it out. So yeah. Pregnancy also, because of course when you have a little babe, when you have a baby inside your abdomen, it increases the pressure inside. So yeah. And then also surgeries. Yes, previous surgeries in the abdomen increases your risk for hernia because it's an increased weakness in the tissues. And also another one, anything that causes increased pressure in the abdomen, like coughing, chronic coughing, like if you're asthmatic or if you have COPD and you're always coughing, like for years you're always just coughing and coughing and coughing, you're bound to get a hernia. So combine all of that, like you had a previous surgery plus, you know, you have a pregnancy or you start coughing, then you have a hernia. Those patients, those women who have a C-section and then have bulging, it's probably because after, you know, they had a surgery done and then they get pregnant again. So, and then if they had a lot of pregnancies, they always have the same incision done in the same spot, so it becomes weak, and that's why they have a hernia. Okay? Another thing to be paranoid during pooping. Yeah, it's... Sitting long in a toilet does not just mean increased risk for hernia. It also increases your risk for hemorrhoids. If you're just sitting so long in the toilet and, you know, what happens is you increase the pressure in your abdomen. And it also increases the risk of you having hemorrhoids. Lalabas ang colon niyan. Nangyari sa auntie ko yan ng bata pa kaya siya nagdoktor. Oh, Oh, yeah. Toilet for long hours. Paano ako makanood ng anime during work niyan? Eh, bakit kasi... Why is sitting for hours in the toilet in the first place, okay? You're not supposed to sit in the toilet for hours, yo. Working out. Working out can also increase your, you know, especially if you had a surgery done and you start working out, anything that increases your abdominal pressure, then yeah, you have a risk of having hernia, okay? Alright, complicated hernias. Let me drink. Alright. Complicated hernias, this applies for all types of hernias. So, inguinal, ventral, incisional. Okay. Oh wait, what's this? Is it true that you need those ball supporters when you're doing sports when you're young? They said I needed before and I don't like the feel. Oh, it depends. They probably let you do, if they found out that you have a hernia when you were a baby, in inguinal hernia and when you were a baby, then they probably want you to wear that because your hernia might get bigger. That's probably it. If you were born with a hernia and it was still there since you were a child, then that's probably why. Okay, complicated hernias. So, when you have a hernia, when you guys have a hernia, no matter where it is, in the inguinal area, if it's incisional, if it's a ventral hernia, if you have a hernia that wherein there's a bulging, but you're able to put it back in, like you're able to push it back in, it's called a reducible hernia, okay? And those kinds of hernias are not, they're not an emergency. You can have surgery done on them electively. Like, they're not something like you have to rush to the ER and, you know. It's something you can just go to the outpatient department and then have a elective schedule. Okay? So, now if we have incarcerated hernia, this is when you have a hernia and then the abdominal contents pass through the hernia and you cannot put them back in the abdomen. Okay? You can't put them back. So, this one needs surgery, especially if you're not able to put them back. So urgent, meaning you gotta prepare them for surgery. But there is a thing we call taxis. There's a technique we do called taxis. So this is when, let's say, you have a hernia, it hurts. You go to the emergency room and then the doctor will look at you and what he's going to do is gonna ask you, how long has this been? How long has it been when you when you got this bulge? If you say like, oh, I had it like 3 hours ago. 3 hours ago, okay? The golden period is around 6 hours, okay? Golden period is 6 hours. They're gonna try to put it back in. So this the maneuver or when doctors try to put it back in is called taxis. Okay, it's called taxis. It's when we try to put the contents, we try to push this back inside. Okay, when doctors do that, it's called taxis. Sometimes if it's in the inguinal area, we would put ice pack on the inguinal region and then have the patient what's this? Have their legs up, like raise their legs. So you would be in a position like your position would be like that. The legs are up. The legs are up. Okay. And you have a bulge there, bulge. So you put ice pack there, and we give pain reliever. So what happens is the muscles will relax, and then it'll be easier to put the contents back inside the abdomen. Okay, so that's called taxis. It says you don't just get it; you're only born with it. It depends on the hernia. Inguinal hernias or Umbilical hernias, you can be born with it. Depends. So, the golden period is 6 hours. What happens if you go past 6 hours? Okay. If you go past 6 hours, this is when we start thinking it might be strangulated. Okay, so this is past 6 hours. Strangulated means that the abdominal contents that pass through are strangulated. So there's loss of blood supply. Because when, let's say you have an intestine that passed through the hernia and they swell up and they get trapped there. And because of the swelling, the blood is not able to flow into that part of the intestine. So when you have no blood in this, if you don't have blood in a certain part of your body, that means you don't have oxygen in that certain part of the body. Because blood brings oxygen around your body, right? So if you don't have oxygen, then just like the whole person, if you don't breathe oxygen, you're going to suffocate, you're gonna die. So that's basically also what happens here. No blood is able to pass through, so no oxygen is able to circulate in this area. So that part of the intestine is gonna die. It'll rot, it will necrose, it'll die. So if surgeons suspect a strangulated hernia, strangulated, that is an emergency. It's a true emergency, okay? That means you have to bring this patient to this operating room like stat, like really. Prepare this patient for surgery, bring him up there. Atrophy? No, not atrophy. Atrophy is different. It's necrosis. Okay? So yeah, this is the true emergency. So how will doctors know? How will we know the difference between a strangulated from an incarcerated? An incarcerated hernia will be a bulge that's a little firm but not too painful. Not too painful. Sometimes it's painful, sometimes it's not. Okay? A strangulated hernia will be very painful. One, it will be painful. There's pain, it will be painful. Two, there's discoloration, okay? Discoloration of the skin overlying the hernia. Discoloration. Okay, discoloration. Like, it'll be, like, purple. That area of the skin overlying the hernia, it's gonna be purple, it's gonna be warm to touch. It's gonna feel warm to touch. Warm. Okay? So, that's how we know. Also, we can, use laboratory blood tests to tell. So, usually if it's like that, blood tests, especially the WBC count will be increased. Like, it will be increased. Sometimes, like, it can reach up to the 20s, man. Okay? And overall, the patient would look like... overall, the patient would be septic. Really look sick. Sometimes there's fever. Okay? Treatment. Okay, we're gonna go to treatment now, okay? So, guys, do you have any questions so far? Any questions, chat, so far about hernias? Before we go to treatment? For treatment, the last time I talked about inguinal hernias, it was very brief, but this time I'm gonna talk about the different techniques in treating hernias. But mostly, I'm gonna talk about the common ones. Because there's a lot of different techniques for treating hernia. I saw on a TV how some shepherds strangulate the testicles of sheep they want to castrate and the balls of the... Oh, yeah, that's how they do... That's how some people treat hemorrhoids too right now. They ligate them. Until they, like, just dry up and fall off. That's kinda... morbid, though. Anyway, guys, have any questions? Okay. I guess there's none? We'll go forward. Or wait. Are there any any other differential diagnosis that will cause those kind of hernia? Differential diagnosis for hernia? Depending on the location. If you want... Oh, oops. If you're gonna talk about the... Okay. Differential diagnosis for hernia. If we're gonna talk about inguinal hernia, you can have... hydrocele. Hydrocele is when you have water in the scrotum that's not supposed to be there. Usually it coincides with hernia though. Another one is wait, what's another one? Tumor. Okay, tumor. Testicular tumor. Testicular tumors, especially on males. they can look like hernias. Like testicular tumor can look like a hernia in that reach the scrotum because it's bulging. Oh wait, what do you mean by different? Oh, you mean like causes of hernia? Causes of hernia? I thought you meant different. I thought I got confused there. When you say differential diagnosis, it means other diagnosis that can look like a hernia. Are you talking about like causes of hernia? Getting punched doesn't really... No, getting punched real hard doesn't cause hernia. Trauma, it depends. It can. Let's say you got shot. Wait, let's say you got stabbed or shot that violated the fascia. Anything that violates the fascia. You can eventually have a hernia. It will take a while, but you'll have a hernia there. But trauma, not really. Blunt trauma, no. Are there enlarged? Yes, that large lymph nodes. Yes, as a differential diagnosis. Inguinal lymphadenopathy. The problem is when you say inguinal lymphadenopathy or lymphadenopathy, you have to find out what's causing this, because enlarged lymph nodes, like why do you have enlarged lymph nodes? You have to find out why. Inguinal lymphadenopathy is very, broad. Like, it has many causes. Inguinal lymphadenopathy can be caused by, especially on the right side, it can be appendicitis. The cause could be appendicitis. It can be TB, tuberculosis. It can be something as bad as like lymphoma, a cancer of the lymph nodes. There's a lot. You have to, when you find a inguinal lymphadenopathy, you have to know the cause. But I guess if it's large enough, it can look like inguinal hernia. For inguinal hernia only, okay? Not like other hernias, like incisional hernia or something like that. Okay? So anyway, let's go to treatment. Okay. First one is herniatomy. Herniatomy is usually done in pediatric patients and children. So what we do is you make your incision, you access the hernia site. You remove the hernial sac, which is this white one right here. Wait, hold on. The white one is the hernial sac. How come I can't click this? Oh, there we go. This white one is the hernial sac. You have to remove that. You remove the hernial sac and then you cut it and then tie it up. So it's high ligation. High ligation means you just tie it up. That's it. And then you just remove the sac. And then you close the patient. This is done in pediatric patients. Okay. Next is herniorrhaphy. Okay? Herniorrhaphy is when you do both a herniotomy and then you do a tissue repair of the posterior wall or the wall behind the inguinal canal. Okay? And so basically it's just whatever was done in the pediatric patient plus more, plus suturing. There are different types or different techniques for herniorrhaphy. The most common one that I've seen or that most people know is the Bassini repair. Bassini technique. So, this is just an example picture, okay? The black strings, the black lines are the sutures. So, what you do is you just open this and then just suture them together. Okay? It's a little complicated. It's a little complicated to look at. If you're not familiar with the anatomy of the inguinal area, this can look really, really confusing. But it's basically suturing the tissues together behind the spermatic cord. Okay, this is the Bassini technique. Another tissue repair technique is the Schuldeis, which I have never seen before. And as far as I know, people that say there's actually a hospital or an institute that specializes in Schuldeis. Like they're the ones who are experts at this, because this is actually kind of complicated to do the Schuldeis technique. It's pretty complicated. Even I have never done this one before. I have not done this one before. I would like to know how it's done, but how to do it, but yeah. Okay. Another technique is the McVeigh technique. So this is where when you suture the what's this, the tissues together, the fascia together, and then you make an incision on the side, like a relaxing incision. So that's the McVeigh technique. By the way, for those who are in surgery or want to do surgery, plan to take surgery specialty, you gotta know all these. At least not know how to do it, but you gotta be familiar with them. Like, they will ask this in exams all the time. This one is a somewhat new technique. The Desarda technique was done by I think it was done by an Indian guy named, I think it's Indian, named Dr. Desarda. So it's kind of similar to McVeigh, kinda. Except that you, aside from making that relaxing incision, you're gonna suture it to the other end of the external oblique. This one I've done before. And you know what's funny? Not many surgeons know how to do the Desarda technique, but it's on YouTube. It's on YouTube, and it's very easy once you watch it. Once you watch it on YouTube, it's actually a neurosurgeon. You're like, oh, it's that easy. Okay, all right, let's do it. Let's do it. And that's how I learned Desarda technique. And they actually asked that in my exams. They asked me, like, I was asked in an oral exam, alright, how do you do the Desarda? How do you do the Desarda technique? I'm like, ha! This is how you do it. You do this, cha-cha-cha-cha-cha. And they're like, okay, I got a perfect score there. Like, and then my other co-residents were like, how'd you know how to do Desarda? I'm like, hey, there's YouTube, man. You gotta watch it. And I sent them the links to YouTube. Like, dude, watch this. Watch this. It's all there. YouTube. One of the rarest. No, I literally learned it from YouTube, okay? No, there was no consultant or no teacher that taught me how to do this. I just watched YouTube and read it. And I... The source of all knowledge. Hey, yeah, you know what? Hey, those Indians that make videos on YouTube on how to do certain surgeries, they help a lot. Those Indians, those Indians that have been making videos, they are ahead of their time. They were ahead of their time back then. because they're the only ones who ever do those. And those videos are actually very, very helpful. They make it very simple. It would be cool. You know what? Maybe I should be like those Indians. I'm gonna be the VTuber that teaches you how to do this surgery. Dr. ShioriPon does Desarda technique. I'm gonna take a video of it. Ask the patient for consent. Like, okay, can I take a video of this? I'm gonna make a YouTube video out of this. But don't worry, we're not gonna reveal your name. You know, personal identification. Just need to sign your consent right here. Okay. And I'm gonna thank the patient. Hey, your surgery just gave me 20,000 views. Thank you. DIY surgery. You just have to be patient when watching. Yeah. Like if you're a surgeon and you are let's say you've been reading, you know, see, if you've been reading your books on surgery, if you're like me that can't just rely on books, like there are different types of learners, right? Some people can get it when they read their books, like they just read it and they understand everything. There are different types of learners. There are also the visual learners, the ones that need to see it happen in front of them for them to learn it. That's me. I have to see it done while they're explaining it. And then they tell me, okay, this is what you do. Watch out for this structure. Do this, do that. That's how I learn. Hands-on, yeah. And, you know, sometimes there's YouTube videos. If you watch a really good one by one of the Indians, it's really good. They help a lot. They make it so easy to understand. So yeah. So if I have a patient that needs a hernia surgery and I don't want to use the mesh, I will do the Sarda technique. Anyway, herniorrhaphy, this is more on tissue repairs, okay? So, but see, the gold standard is a hernioplasty. The gold standard of a hernia repair is a hernioplasty, wherein you use a mesh, okay? And that technique where you use a mesh is called the Liechtenstein procedure or the Liechtenstein technique. This is an inguinal hernias, okay? So you basically put a mesh. You open up the hernia, like, let's go back here. You open up the hernia, take out the sac, you do what you need to do, and then you place a mesh before you close it, before you close up the incision. The mesh is what gives strength to the area. Okay, this mesh, it looks like a little mosquito net. It looks like a white net. It gives strength to the area so that, you know, it doesn't the hernia doesn't recur or happen again. Okay, so it kind of looks like this. Okay. So most patients who undergo repair of an inguinal hernia, majority of them have a mesh. Okay, majority of them have a mesh because this is the gold standard. When you do a hernia repair, you gotta put a mesh. Is the mesh titanium? No, it's polypropylene material. It's not titanium. They call it polypropylene. Extra layer of reinforcement. There's different type of meshes, but this one right here is a polypropylene. Oh god, I can't click the thing. Polypropylene? Polypropylene. Did I spell that right? I think I spelled that. I think that's right. Polypropylene. I think that's right. Why are high tension techniques Bassini still carried out when techniques like... Okay, I'll tell you why. That's a very good question, Ikathios. I will tell you why. Oh wait, here, let's go back here. Let's go to Desarda. I'll tell you why. When you have a reducible hernia, a hernia that is not complicated, then yes, you use a mesh, okay? Use the mesh. But if you have a hernia that is strangulated hernia. A strangulated hernia means that the bowel that was passing through the hernia defect is dying. Most of the time, majority of the time, actually no, not majority, all strangulated hernias have necrotic tissues. Strangulated means the tissue has necrosis. That means it is dying, it is rotting, it is dirty. It is a dirty dirty surgical site. And a mesh is considered a foreign body. No matter how clean it is, no matter how sterile, it's considered a foreign body. It is not a normal material that is, placed inside the body. It's not normal. So if you place a mesh in a hernia repair where the hernia was strangulated, you increase your chances of getting infection. And when you have increased chances of getting infection, you have increased chances of recurrence, because infection is also one of the causes of recurrent hernia. So the only time you put a mesh is if the environment or the hernia itself is not strangulated. You can use it if it's an incarcerated hernia or a reducible hernia. But if it's strangulated, you have to do a tissue repair. That is the time you do a tissue repair. Okay? That is why other surgeons still do the high tension techniques, the Bassini and all that. Because it is, you have to repair, even if you have like an infected hernia, strangulated hernia, you have to repair it one way or another, and it's by tissue repair. You can't use a mesh. You have to put a repair. So it depends on what technique you know. Some majority of surgeons know the Bassini technique. Some experts know the Scholdice technique. Desarda, but Desarda is pretty new, so some surgeons know that. McVeigh is usually for, I forgot to mention, McVeigh is usually for femoral hernias. Okay, femoral hernia. I have not done this before, so I am not that familiar on how it's done. So I won't be able to explain. I won't be able to explain this one. Thanks for answering. Yeah, no problem. Okay. Okay, the next one is laparoscopic repair. So it's basically like instead of just like having a large incision in the inguinal area, because when you do an open inguinal repair, the incision is usually like here, or like sometimes it's slanted like that. In laparoscopic hernia repair, they just use like 3 incisions. One here, one here, one here. And the repair is done from inside. Unlike an open repair where you repair from the outside, right? Or when you repair from the outside or on top. This one, the repair is at the bottom. And laparoscopic hernia repair is getting popular here in the Philippines. But not every surgeon here in the Philippines is an expert at this. Like me, I am not an expert at this one. This is usually done by the minimally invasive surgery subspecialties. Doctors who are specialized in minimally invasive surgery. Although, as a general surgeon, the most common minimally invasive surgery that we know is laparoscopic cholecystectomy, because that's the gold standard. Okay? Okay. So there are 2 types of laparoscopic repairs. We have the tap and tep, the transabdominal and the extraperitoneal repair, which I am not which I have never done before. There's a top and tip. God. Okay. Next. Oh, okay. This one is an additional slide I placed. For those who want to know where you place the mesh. This is for mesh placements in ventral hernias. Where do you place the mesh? There are many places you can put the mesh in. So this is like a cross section of the body. Wait. This is a cross section of your abdomen, okay? So these are these two bulges, these two muscles here. These are your rectus abdominis muscles. And let's say you have a ventral hernia. You can place the meshes in like in between or on top of the fascia, or below the muscle but on top of the posterior fascia or the peritoneum. Yeah, this one's the same. Or inside the peritoneum. Nawawala din ba yung mesh or nandiyan? No, it's there. It's there forever. It shrinks a bit, but it's there. He just lived with the mesh. So, there are different places. So if it's on top, like if it's in between, like this is called an inlay. If it's on top, like this is called onlay. Sublay is below but above the peritoneum. And there's also the intraperitoneal. So, majority or the ones I've seen mostly are onlay because this is the easiest one to do. All you gotta do is just open up the skin, go through the fat, look for the defect, repair it, and then just place a mesh. It's so easy, just like that, just like that. But the risks are seroma or infection because it's just there underneath the fat. The retrorectus or the sublay is the more desired one. So because you don't there's less infection. It's a little harder to do, it's more technical, and it's longer to do. And there's a violation of the hernia space, but then this is not much of a big problem. This is the best one among all the places where you put the mesh. Just put it behind the muscle or on top of the fascia here. And then intraperitoneal, this one, it's also difficult to do that. But you have the risk of like violating the internal organs. So yeah. This one is like surgery stuff. If you're taking surgery residency, or if you're gonna plan to be a surgeon, you gotta know all this. But as a med student, I don't think you need to know this. You just need to know that when you repair a hernia, you put a mesh. Gold standard, put a mesh. I think that's all you need to know as a med student. And also that Hasselbalch's triangle, which we don't even, as a surgeon, you don't even pay attention to anymore. Buti pa yung mesh nag-i-stay. Yeah, imagine if you got a hernia and then you had a mesh. Your partner will be the mesh forever. Okay. Exploratory laparotomy. Oh, this one is for, we usually do this, like, if you have a strangulated hernia. If you have a strangulated hernia, you cannot just repair the hernia from the inguinal area. If the hernia is strangulated, you have to open up the abdomen. Because you never know that the bowel or whatever is here is the only one that has been that's necrotic. There might be some necrotic bowels inside. So yeah, every time there's a strangulated hernia, they will do an exploratory laparotomy. Okay, that's for inguinal hernias. Even if it's like a strangulated hernia in the middle of the abdomen, yeah, it's always a midline incision, a exploration or exploratory laparotomy. Okay, and recurrence rate. Oh, okay, yeah. What is the recurrence rate of a hernia? I think here we go. Lowest recurrence of the repair was a hernioplasty or the Liechtenstein technique. It's only like less than 2%. Sometimes even less than this. If it's a tissue repair, it's higher. But as far as I know, the Desarda technique has a recurrence rates comparable to the Liechtenstein procedure. So that's why they're studying the Desarda technique. It's a new relatively new one. They're saying that it's almost as good as the Liechtenstein technique, and that's considering that it doesn't have a mesh. Okay. So, and that is the last slide, guys. Do you guys have any questions? Have you learned from this? Ooh, I actually took an hour 30 minutes on this one. Labia. Hello, bakit? Hello, bakit? Hello, bakit? Tayo ng pangalan yan. Alright. Okay, guys. Did you guys learn? Did you guys learn? I hope you guys learned a lot. You guys have any questions? I will answer them if you have any questions. Oh, ano? Walang tanong. I learned a lot. Thank you. Yung assignment po kailan papasa? Walang assignment pero may quiz. Quiz na lang since walang tanong, may quiz na tayo, guys. Okay? Quiz. Quiz, guys. Since wala kayong tanong, magka-quiz na ako. It's time for a quiz. Get 1/4 sheet of paper. 1/4 sheet yellow pad paper. Yellow pad. Kailangan yellow pad. Hindi pwedeng white, hindi pwedeng high school paper. Thanks for the stream. Are you enjoying specialty? Yeah, I'm a general surgeon. I'm having fun with it. Anong lurk? Hoy! Hoy, bakit may mga nagpapa-excuse? Hindi kayo excused. There is no excuse. When you're researching the topic, sa Google lang ba yung sources mo? Yeah. I mean, like the photos is Google. I like all those photos I have on my slides. Puro Google lang yan. But like when I'm talking about my when I make my slides for medical education streams, they're all stock knowledge or whatever I read from books. Okay. I just get pictures from Google. If I don't want to type what's on my head, I just grab photos from Google and then slap it on the slides, and then I just explain from there. So it's really stock knowledge and whatever I know from the books. Nagka-hernia ako sa quiz bigla. Takbuhan! May training po kami sa bato sus. Okay. Number 1. Okay, chat number 1. Okay, chat number 1. Number 1, ano ang hernia? What is hernia? Okay, what is hernia? Okay, guys, number 1. What is hernia? Okay, sagot! Schwartz ba main ref mo dito, Doc? Yes, Schwartz and other... Actually, I have other books also. Current, I like using current. A lot of it is Schwartz also because I mean that's like the Bible of Bible for surgery. So a lot of the basic stuff are in Schwartz, but like if you want to know more, you have to read other books. True. bulge. A, protrusion. Truths. Ano lumawit na isa. Sabiston? No, I don't actually read Sabiston. Schwartz is more, noob friendly, bobo friendly. I prefer Schwartz over Sabiston. As a med student before, I read Sabiston and it was like, parang hindi nag-ano sa akin yung Sabiston. I prefer Schwartz. Plus, even when you're a resident in surgery, Schwartz talaga eh. It's really Schwartz. Okay. Ano ba tong mga to? True, bulge, A, protrusion, truth, lumawit na isa. Ay, masagot nyo. Sige na nga. Protrusion. Okay, I'll accept protrusion tsaka bulge. Sige na nga. Isaw na lumalabas due to a tear in the tissue. Ay, Taglish. Okay. 2. Number 2. Okay. What do you call a hernia that comes after a previous surgery? Like a hernia that happens after a surgery. What? You stress and as resident myself, time to slay as a VP. Amazing. I'm done with residency now though. I'm done. Round 2. What? Incision bulge. What the hell? Ano pa? Sagot. Incisional hernia. Incision bulge. Round 2. Recurring. Si Hello Bakit lang yung nakatama. Skill issue. Tayo na skill issue. Kawawa naman. Kawawa naman. Kawawa naman. It's like saying, hey, your fascia has a skill issue. It can't even keep your abdominal contents inside your abdomen. Your fascia has a skill issue. Bughat kung Bisaya. I forgot to say that Tagalog. What's bughat? What's bughat? I don't know what bughat is. Incisional protrusion. It's incisional hernia, guys. Pero sige na nga. But incisional hernia, it's incisional hernia. Okay, number 3. Okay, number 3. How old do you repair umbilical hernia in babies? Hernia in babies. I placed the age in my slides. Bah, 5. Alam nyo na. Alam nyo ah. Oh, okay. Sige na nga, 5 na rin. May nangungopya dito. May nangungopya. Okay. Dok, may nangungopya. Oo nga, may mga nangungopya dito. O, sige. Oh, eto. What? What do you call a mesh repair? O, dapat tama yung spelling, ah. What do you call the mesh repair? Mesh repair. Yung proper name niya. Repair of hernia. Of inguinal hernia pala. Inguinal Hernia. Nako. Anong reinforcement? Ano ha? Dapat alam nyo yan. Nilagay. Anina, nasa slide ko yung spelling ha. Dapat tama yung spelling. Oh, first letter. Oh, ito ha. First letter L. Oh ha? First letter L. Oh. Last letter N. Oh ha? Ano yung X? Let's see. Yan. Ay, tama ba? Ayan. O ha? Vulcan lubrication. Lemesh repair. Okay, okay, the ones who got it right. Ito. Oh, Liechtenstein. Oh, si Iberian, tsaka si Ablul. Got it right. Oh, yan, okay. Okay, so, yeah, I think we're good for lick these nuts. Buisit. Nakakabuisit naman. Bonus? Gusto niya bonus? Sige na nga, bonus. Bonus question. Bonus question! Okay, bonus question. Ay, ano ba to? Wait lang. Okay. Bonus question. Sino ang pinaka-hot na Dr. VTuber? Sino ang pinaka-hot na Dr. VTuber? Ako. Si Jose Rizal, tangina. Ano si Jose Rizal? Etong si Wendell, late ka eh, minus 50. Lahat ng mods ko, minus 50 points. Mods equals minus 50. So si Wendell, alam na ko, bagsak na yun. Doc Bello, VTuber ba si Bello? Para iwas demerit si Doc Shiori agad. Hindi na kaya mag-stream. Kulang na lang VT, Bello VT. Ano ba yan? Alright. Anyway, yeah, that is Dr. Bello VT. Okay, but yeah, that is the end of the medical education stream. I hope you guys learned a lot. Let me go back here. Okay. I hope you guys learned a lot from there. Oops. I'm gonna close this. There we go. Kay Doc Shiori na ako paparepair ng hernia. I missed the quiz. Wala na, bagsak ka na, Pokari. Nabis mo na, bagsak ka. Can you do raid here? I don't know how to raid, and I don't even know if I think I have to be mutuals. And that person has to allow raids. Okay lang, nakaligo naman. Ako confident naman tong ni Pokari. Pwede ba magpalagay ng mesh ng advance? No! Hindi pwede. Hindi pwede. Okay. Anyway, I missed the class, but I got my excuse slip. Ay nako. Ay nako. You latecomers. Mga latecomers talaga. Anyway, do you guys have any, before we end stream, do you guys have any topic you want me to talk about next time? About, anything, surgery or medical related that you guys want? Actually, no, I had topics in mind for YouTube. I was thinking, like, medical or medical memes review. I have been thinking about medical meme reviews. Like, I was thinking about doing that. I don't think, have I done that before? I don't even remember. Have I done that? Have I done a medical meme review? I don't think I have. Gout? Oh my god, gout is under medicine and it's not surgery. I know like really basic stuff about gout, but not like it's outside my forte. My topic. Oh, I think I did burns, but maybe I can do it again. Let me see. When was the last time I did burns? But I do have burns. Let me see. Oh, there. I do have burns. Wait, I think... Let me check. I probably have the old PowerPoint here. I am going to check how in-depth my burn was. My burn PowerPoint was. Let me look. Classification of burn. Oh, yeah. Oh, okay, yeah. Alright, I do have burn. When was the last time I talked about burns 3 years ago. I can do that again. Pag switch ng organ. Switch mean transplant? Transplant is highly specialized. That is a very highly specialized topic, so I am not that good at transplant. May matitrigger na IM. Lagi naman natitrigger ng IM, you know. You know what, I can do I was thinking of doing a medical memes review. I just have to look for a place where there's medical memes. Like the only ones I know are the one on Facebook, like Chronicles of MD. Like she's the only one who does like Pinoy medical memes. Like she's the only one. I don't know if there's like any other. I could do like medical memes from other sources too. Gout kasi sabi ng tatay ko, bata pa daw ako para magka-gout nung June 31 na may gout. Oh, God. Oh, that's like... I know some people who have gout even at a young age, man. Nabalitaan ko kasi pag nagsalpak daw ng bagong hindi daw tinatanggal ng lumiluma. Oh, a kidney transplant. I have not assisted in a kidney transplant much. I think I've only assisted in one, so I don't really remember much. And transplant is like more subspecialized. It's highly specialized. Yung headaches na cause ng pagpupuyat, may na-ICU daw sabi nung mga napanood ko sa FB. Baka naman kaka-computer niya yan. Kaka-computer niya yan eh. True cardio. Yeah, I think she's cardio. Chronicles of MD. What's the difference between direct and indirect hernia? I said that a while ago, but direct hernia passes through. There's this what do you call this? Landmark in the body called the Hesselbach's triangle. That's where the direct hernia passes by, and it's more of a weakness in the abdominal wall. Unlike in an indirect hernia, it doesn't pass through the Hesselbach's triangle, and it passes through the canal. The inguinal canal. So it's not much of a wall weakness compared to a direct hernia. The topic na ba dati about yeah, I did bowel obstruction. Wait. I did it was not really exactly a topic, but I think I did it when wait, where is it? When I had to help a patient. Ito ba yun? Ito, I had gastric outlet obstruction, intestinal volvulus, bowel anastomosis and healing. Yeah. I kinda touched the obstruction. Paano nga ba nila tinatahi yung veins? Oh, they used special sutures for that. Like, it depends on how big the vessel is. They use different types of sutures for that. Like, it's a very meticulous surgery. They gotta make sure that the sutures hold and they don't give out. Ricardo Dalisay. Search ko yan. Yeah, I think, let's see. I have a lot here. Like, I have gastric. I can probably redo some of my old streams. Like, the ones I've done 3 years ago. I have one here that says, patient needs help. What is this? Oh no, this one's thyroid. Okay, this one was a thyroid patient. I had one about gastric outlet obstruction, I think. Oh, what the heck? Hey! I did not realize my gastric outlet obstruction, VOD has like, my VOD was divided into chapters. That is so cool. I didn't even do this on my own. Did YouTube do it for me? It's divided into chapters. That's cute. That's cool. Intestinal volvulus. Thyroid. Yeah, I did thyroid. You can check the playlist of my medical education streams. Sup, Doc? How you doing? Hello, Koi. I'm doing good. We're actually done with the with the lecture. I'm just asking for like content ideas. But I will Burns. I can revisit Burns, and I think I'll do a medical memes review. I just need to find some. I was thinking about talking about residency, but I think I did that already. How in depth did I go about that? I talked about residency 6 months ago. Oh, I did. Oh, I did. I talked about residency. Okay. I don't need to talk about residency anymore. Okay. Broken bones na experience manasal pa. That one is broken bones. Fractures are more for orthopedic surgeons, man. I'm a general surgeon. Anyway, yeah, for those who are interested in thyroid, I have one thyroid stream with it was a collab with Ratanak, because Ratanak had thyroid cancer and he had surgery for it. So that one was a collab stream because I had to talk. We used him as like a sample patient. Like Ratanak had a thyroidectomy and an MRND, or a modified radical neck dissection. So he had a really major surgery on his neck. What else? Oh, this one. This one, I am going to rename some of these. The ones that says patient needs help, I'm gonna rename it to like the disease. So it's easier to find. Okay. Oh, are blunders a taboo topic? Huh. OR blunders. It might be a little... Okay, OR blunders might be a little bit... I can probably talk about that if it's like an issue that was a past issue, something like that. And then what we can do is just talk about what happened, why it happened, what could have happened, something like that. But then I would need to like look for issues like that. Like, for example, a patient that died during surgery. It's actually complicated. That's a complicated topic, actually, because I can't. It's hard to really talk about something like that because I'd have to know like both sides. I have to know. I can only speculate what could have happened. That's gonna be hard. Anyway, yeah, that's all. I guess that's it. I'll see what topic I'll talk about next week on YouTube. It's either burns or maybe we'll do the medical memes if I can find any. You know what I also plan to do? If I could get monetized on YouTube, I can probably do a medical watch along, like medical dramas watch along. It's something I planned, but we gotta get monetized first. I need memberships. We gotta get memberships. So IG madami medical needs. Yeah, I'm gonna look for some. I'm gonna look for some and grab some. Anyway, yeah. It is 10:58. Thank you guys for coming to my stream. I hope you guys learned a lot. My next stream will be on YouTube tomorrow. I know, not YouTube, Twitch. Twitch pala, not YouTube. My next stream will be on will be tomorrow in Twitch. I'm gonna play mouth washing, which I haven't downloaded yet. I gotta download it. Buhay pa ba yung criticized dog? Oh my god, please, let's not. I hate it. I don't even want to watch it anymore. It was annoying. That was the most annoying. It started good, but then it dragged so long and it was getting stupid. Yeah, I'll be playing mouthwashing. Okay. Alright, Atsupang guys, thank you so much. I'll see you guys tomorrow on Twitch. For those who are new here, for those who are new here on my channel, I stream most of the time on Twitch, so you can catch me there. I also have a Twitter. That's where I put my stream schedules. But then I also post it here on YouTube on the community tab, so you can just check when I'm gonna stream. So, and also, if you're not a Twitch person, I upload my VODs on a separate YouTube channel, the ShioriPon VODs channel, so you can check that out. I usually upload them and I premiere them, so they looks like a live, but it's not a live. Yeah. Okay. Oh, thanks for linking them, Wendell. Thank you. Alright, guys. Alright, Atsupam, bye-bye, good night. Bye-bye.